Okay, so it's noon. Welcome everybody to the first in our series of webinars alongside the Cognitive Impairment Independent Drinkers project being run by Alcohol Change UK. And we are very honoured to have Professor delivering the first webinar for us here today. Before we get started, however, I'd like to tell you a little bit more about the project. I'm Lauren, by the way, Lauren Booker, and I'm one of the consultants working on this project. So some of you may have seen me before. If not, some of you might be seeing me in training later on this year. The project itself is a collaboration between 25 partner authorities and organisations, all being involved in the development and dissemination of this work. So far, we've held workshops in all 25 areas and consulted with far and wide with a number of organisations to develop guidance on supporting dependent drinkers who may be experiencing cognitive impairment. That is leading to the development of national guidance on this issue, which is currently in draft form, and we hope to publish that in a few months. This webinar series, 7 webinars, I'll tell you a little bit more about those in a second, complement the series and really show some of the, showcase some of the knowledge that is around the UK. So we've got experts in a variety of disciplines talking to us over this webinar series. This is being followed by training. There are 4 training sessions available in each partner area. Those can be accessed via the Eventbrite link, and your local authority should let you know about that training. If not, please do get in touch with them and get the information if you'd like to attend one of the training sessions. And that will be followed by the publication of the guidance. So a little bit then about the webinar series. There we go, this is the first. The times is 12 p.m, obviously, not a.m. Professor Ken Wilson. So next week we have Using Legal Powers from Professor Michael Preston-Shute. The following week, Living with Korsakoff Psychosis. My colleague Mark Holmes and a colleague of his who has lived experience of Korsakoff's will be delivering that webinar. We then have Dr. Rafi Faruqi talking about understanding memory, brain injury and neuropsychiatry services. Followed a week later by Grant Brand talking about the Glasgow model, which is a very effective model that's being used in Scotland. Dr. Julia Lewis on the use of Pabrinex, the prophylactic use of Pabrinex with this client group. And finally, Lee Andrews, who is a speech and language specialist, talking about the importance of using speech and language therapy with cognitively impaired drinkers. So that's what you've all got to look forward to. I'm going to stop my share at this point, and I'm going to tell you a little bit about, I'm going to do 2 things at once, hopefully. I'm going to tell you a little bit about Professor Wilson, and I am also going to hand the hostship over to Ken so that he can show his slides. She says hopefully. Okay, right, so Professor Ken Wilson is a retired head of Department of Psychiatry at Liverpool University, medical director of the Mental Health Trust and director of the Northwest Coast National Institute of Health Research Network. That was a mouthful. Last 20 years of clinical work have included the establishment of a community alcohol-related brain damage service, which won the Royal College of Psychiatrists Community Team of the Year Award in 2012. Professor Wilson has conducted numerous real-time clinical audits and follow-up studies of people with ARBD. He was the lead editor in the Royal College of Psychiatrists ARBD guidelines and has contributed to numerous other national guidelines, reports, and other publications. He has extensive experience as an expert witness in family courts relating to capacity assessments in cases of ARBD. On retirement, he helped set up the ARBD network, which focuses on promoting services for people suffering from ARBD through education and research. And that is arbd.net, if you'd like to check that out. A couple of other things I'd like to mention. If you have any questions, please do pop them in the chat. There will be time at the end of Professor Wilson's presentation for him to take questions. So pop them in the chat and I will feed those to him at the end of the presentation. This webinar is being recorded and you will be able to access a copy via your local authority. Do give us a few weeks though to sort out all the webinars and make that happen. So yes, all the presentations will be recorded. Okay, so anybody who's unable to catch any of those, you will be able to access the information later. And on that note, I would like to now hand over to Professor Wilson.
Thank you very much, Lauren. Can you hear me, everybody, and everything's okay, is it?
All good.
Great. Okay. So Lauren asked me to really concentrate on this question here, ARBD, what is it? I'm going to start off with just an overview slide to really address the concept, and then we can explore it further over the next 40-odd minutes. This is the overview slide, and fundamentally, alcohol-related brain damage, you see, is an umbrella term, and it's really designed to capture all those conditions that involve cognitive deterioration as a consequence of alcohol misuse and related thiamine deficiency. Now you can see from these Venn diagrams here that actually it's the biggest presenting feature of alcohol-related brain damage is fairly subtle, and actually you'll see later in the presentation fairly common, and it's a subtle, slow onset of changes in cognition affecting reasoning and then subsequently memory. So there's lots of people who are very heavy drinking who have these problems but are functioning on a day-to-day basis. But their family and friends and people like that will have actually noticed that there's change in them. You'll see the red circle there, that addresses Wernicke-Korsakoff's, which is really the sort of most well-known syndrome associated, or in this umbrella, within this umbrella term of alcohol-related brain damage. But actually in its pure form, unless you're on a sort of ward that deals with gastrointestinal or liver problems, it's actually relatively rare in the general population. And of course, it is associated with high mortality if not addressed and treated. But you'll notice also that there's a variety of other neurological and cortical disorders which can be associated with alcohol-related brain damage. And please don't ask me too many questions about central pontine myelinosis and Machiavelli-Biganami syndrome, because actually I might have come across them, but I've never seen them that I can remember. So I don't have much clinical experience of it. And most importantly, there's about 25% of people with alcohol-related brain damage problems will also have experienced some microvascular disease in the deep part of the brain, and or some minor trauma. Now, obviously, if vascular disease, cerebral vascular disease or trauma is a main presenting feature, then that will override secondary changes just because they've been picked up on a scan or something. So fundamentally, that's the overview picture. Now, it's rather cold, sort of Venn diagram-y picture. So I've given quite a lot of thought on how to present alcohol-related brain damage in a more meaningful way. So what I've done is I've recruited lots of examples and amalgamated them into a made-up patient that will go through this person's journey. And it is fairly typical of the sort of cases that our team has been dealing with over the last 20-odd years. So I'm going to introduce you to Jean. And this is incidentally a picture drawn off the internet somewhere. Now, Jean is a fairly straightforward case. She's a 42-year-old, married, no children. You can see that she's running into some significant family sort of problems. Her husband's walked out on her. She's really It's not an unusual picture in this world in which we're talking about, is it? She's probably left in her own house, living off what savings left. And they've always been heavy social drinkers, but now you can see that the context is set for her to become quite severely dependent, I suppose. So here she is, and I want you to empathize with her. We've all been through bad times in our lives, and I can imagine her having restless and miserable nights and worrying about things. And this goes on for a number of years. And you can see that anger and regret, things start falling apart a bit, don't they? Her world is getting that much smaller, isn't it? Her elderly mother's concerned, roped in the brother who's trying to phone her up, but sometimes he's drunk. She's seeing herself as a progressive failure, really. The breakup of her marriage, the lack of children, failure as a woman, as a wife. I can just try and imagine some of the horrible things that are going through her life. Well, her brother was getting quite worried about this, and of course alerted the GP. So the GP gets one of the community nurses out to see what was going on. Called in the afternoon, and that's when Jean's really had a bit too much to drink, and she was very uncooperative, really. And she didn't want any help, really at all. The nurse actually managed to get into the house and sat down with Jean to try and talk her through. And you can see from the nurse's perspective that things were deteriorating, really. You can see her sleep pattern had gone. She'd become apathetic, lack of self-care. There's that sort of smell that you can get in some houses where clean and you're not sure what you're smelling, and the fridge was empty. Things were getting pretty grim. And you come out of that sort of house, don't you, and say, oh God, Bennett, how awful, this poor woman. And you can't help but say, God, something's really pretty grim here. So anyway, the nurse tried to pull in the alcohol treatment services, the local alcohol treatment services. And a counsellor called on Jean. And of course, Jean was a bit irritated and said, look, I don't want to, it's not my thing. Don't come into my house. I don't want people around. But the counsellor was very good and persuaded Jean to come along to the local unit, which was, a bus ride away or something like that. And she got in and she had a brief introduction to the staff there and met a couple of the other clients there. And it looked like it might be coming together a bit. But she failed to turn up on the second appointment. Now, I don't know how routine this is, but a lot of alcohol treatment services might have protocols on what you do when people lose contact. And this particular organization had a 2 or 3 hit, and they'd go around to the house 2 or 3 times. But Jean was getting more and more adamant that she didn't want to be involved. So she was left with contact details. Now, in my experience, that is not an unusual sort of finding or experience working with these clients, patients.
It's exciting.
She's quite a broken woman, you can see, and she's
Robert Henry.
quite distressed. Over the next year or so, where she picked up her alcohol, it was just up at the off license, which is sort of a veg store as well, and they noticed that she was more disheveled and she was getting a bit thinner. She was tending to smell a bit from not washing. And it's quite interesting, this confusion they noticed. She'd go in and she'd ask for something, she'd buy a bottle of whatever it was and come out, and then maybe the next afternoon, that afternoon, she'd go in again and have a repeat conversation and tell them things that she'd told them in the morning. And so sometimes they weren't sure whether she was talking about reminiscing about living with her husband or whether she believed she was living with her husband. It was sort of, it fluctuated. And occasionally they said, no, Jean, you don't need to give me this sort of money, you need to give me that. And this sort of thing was going on. And they were a little concerned. They knew Jean of old, of course. So, but one of the most interesting things that was coming on is that Jean really was fairly adamant that she had no problems. Now, I just want to stop and pause here because it's quite interesting. Jean's house was in a state of neglect. She was physically deteriorating. She obviously had some significant cognitive problems of a fluctuating nature. She looked awful. And yet, when said, how are you? She'd say, I'm fine. Absolutely nothing wrong with me. And this was a persistent and entrenched sort of feature of her presentation. So we have to ask ourselves, what's actually happening to Jean? As clinicians, we have to say, okay, why is Jean like this? Now, the easy answer to that is to say, well, she's an alcohol dependent. But people who drink a lot of alcohol don't get the sort of confusion that she has all the time or frequently. It's actually, there's something else going on here as well. I mean, we know she's intoxicated, usually from half the day onwards into the evening. We know that she's deteriorating physically, socially, and psychologically. And we know that the interventional services couldn't help her from her perspective. And now she's denying that there's a problem when any party walking down the street can say, this woman's not well. Now, if we had been able to, and we'd done a scan, we would have seen this. And in this scan, what we've got on the left, and now I don't pretend to be a scan person, but on the left there, you can see the brain, cross-section of the brain, and you can see the blue-gray parts. That's the cortex and the brain matter. And look at the person who has alcohol problems on the right. You can see the black gaps are much greater. And this is because of brain cell death. Shriveled brain cell death, and brain cell shrinking. And there's something seriously going on in Jean's brain. There is no doubt, you see, that almost certainly alcohol has long-term effects on the brain. We don't know much about the direct long-term effects of alcohol on the brain, but we do know that alcohol interferes with vitamin B1. Now, this does it in three principal ways. If you're a very heavy drinker and you're drinking a lot of calories, what's happening is your diet changes, as did Jean's. And you know, when you've had, I know it happens to me anyway, when you've had a glass of wine or three, and you get the munchies afterwards, and there's nothing like a sort of something to, that's usually carbohydrate. So when you're heavy drinking, you can actually increase your carbohydrate intake. But you're reducing a whole variety of other foods. So the amount of thiamine or vitamin B1 going into your body can be dramatically reduced. Second point is that thiamine is absorbed from the gut into the blood. Alcohol prevents that absorption from the gut. So even if you're taking excessive thiamine and you're drinking, you're going to diminish the amount going into your blood. And lastly, but not least, now this is a bit difficult for me to describe, but within cells of your body, nutrients are changed into energy by a very complicated chain of chemical reactions. And thiamine, vitamin B1, is integral to allowing that chain, those series of steps, chemical steps. Now, when alcohol gets into your brain, into your body cells and brain cell, it stops the thiamine from working in that chain. Consequently, you can't change nutrient into energy. And what is the organ that uses the most energy in your body? It's your brain. So your brain starts suffering first. So there is certainly an indirect effect of long-term chronic alcohol misuse on the brain, either direct and definitely through the effects of reduced thiamine effect. So what does this do to one's intellect or cognition, as we would use from a clinical perspective, their cognition? Well, the next slide is a series of research projects that have actually been done on people in communities and in residential alcohol treatment services. And I want to just very briefly take you through this because you can read it yourselves, but you can see as you read this, I want you to think of Jean. I would suggest to you that without too much leap of an imagination, if you've got these cognitive problems affecting the front part of your brain, and this is the reasoning problems that was in that original diagram, then this is going to have a significant knock-on effect on the way Jean is living. Look at those problems she's experiencing. That breakdown in interpersonal relationships, what's that about? That's not necessarily about arguments and things. That's perhaps, and it's been shown by some studies, that person's ability to empathize is being damaged. Their ability to understand how other people see them and how they see themselves. And let's just make some simple leaps here. And these are just some examples. How are these cognitive changes beginning to affect Jean? Well, I would argue that there's, on the face of it, it's not too difficult to actually suggest that some of these issues on the slide now are a consequence of the cognitive change. So I'm presenting to you now that actually Jean's problem is not just alcohol dependency. It is thiamine deficiency related cognitive change concurrent with alcohol dependency. And I want to explore that bit at the bottom, poor compliance to treatment programs, a little bit more. Because why did she not find the alcohol treatment services helpful? Well, let's have a look. If you've got these cognitive changes, how are you going to switch from topic to topic in a group setting? How are you going to empathize with people? This idea of cannot cope with complex abstract concepts. What is an abstract concept? Well, what is dependency if it's not an abstract concept? What is alcoholism if it's not an abstract concept? And then relating those concepts, which you might have a struggle with, to yourself. And then on top of that all, you've got concentration problems. So after 3 minutes of a conversation, your mind is wandering. You can't engage with the people in the treatment unit because you can't empathize. You don't see any of yourself in them or them in you. So you can see how a bog standard alcohol treatment service or any other service that requires interpersonal relationships and discussions are going to cause our gene some significant problems. But interestingly, and I want to come back to, why does she deny she has a problem? Now, those people working with alcohol-dependent clients, alcohol misusers, heavy drinkers, will have come across time and time again those people that say, when it's quite obvious to you they've got a problem, and they will say that they haven't got a problem. And let's confront this. What is going on? Well, from a lay point of view, and from my point of view, I would come in and say, well, perhaps there are some understandable reasons that they're denying that they've got a problem. You know, maybe they're embarrassed. Perhaps they want you to mind your own business. Perhaps they don't want, they think there may be strangers in the house if they, you know, people telling them what to do. Or perhaps they don't like attending the alcohol treatment services. It could be a whole mishmash of obvious, logical, understandable issues. But those people working with alcohol treatment, in alcohol treatment services, will have come across, and indeed anybody working in mental health services will have come across the concept of psychological denial. Now, psychological denial is fundamentally a Freudian term, and it is what we call a defense mechanism. And what psychological denial is it's about squashing down those thoughts that cause you anxiety. Now, if you are a heavy drinker and that drinking has caused you all sorts of problems, as in Jean's case, perhaps, breaking up of your family, of relationships falling apart, goodness knows what, financial problems, social problems, whatever, you're going to find admitting that you have an alcohol-related problem quite difficult and quite anxiety-provoking. Guilt, worry, anxiety. So there's quite reasonable defense mechanism of denial. And I think everybody's familiar with this. In fact, it's embodied in the STEP approach to denial, confrontation, and dealing with denial is often embodied within the counselling that alcohol treatment services provide. However, ladies and gentlemen, I'm going to introduce you a slightly different concept. And I want you to think about this one. We know irrefutably that if you drink enough alcohol in enough quantity for long enough, you're going to get brain changes. Point one. Point two, you're going to, as a consequence, have cognitive change. And point three, your insight into your problems is actually a consequence of your thinking. If you damage the part of the brain that enables you to realize you have problems, you will not realize you've got those problems. Does that make sense to you? Now, anybody, let me just illustrate this a bit further. This guy, Rin, back, oh gosh, umpteen years ago now, did a survey in an alcohol treatment unit. I think it was both community and inpatient, I'm not sure. But it was a big survey of those people that failed to reach their agreed targets within the program. And they found that they could predict with quite reasonable efficacy that these people had these types of cognitive problems. So cognitive problems were associated with problems in achieving alcohol treatment service goals. And that's really summarizing perhaps what happened to Jean. But this next study is even more interesting. that when you interview people with cognitive damage, who got ARBD, proven cognitive damage, they deny having the cognitive damage, which is quite fascinating, really, because now you might be dealing with people with cognitive damage, and when you test them, they've got cognitive damage, but when you speak to them, they say nothing wrong with them at all. Now, is this just an alcohol-related brain damage problem? No. I come from a background of working with younger people with dementias for many, many years. And one of the types of dementias that you come across, for example, is the frontotemporal dementias. And anybody that's worked with frontotemporal dementias, the front part of the brain is hit, just as in ARBD, they will know 99% of patients, no matter how bizarre their behavior and how confused their thinking is, they say they haven't got a problem. And this has been described by Babinski many, many years ago. And fundamentally, it is the damage to the part of the brain which gives you insight into your illness. And subsequently, Professor Kaufman has found this to be the case in people with alcohol-related brain damage of varying degrees. So how do we make sense of this? Well, this is my way of perceiving it. Fundamentally, if you've got a heavy drinker and they progress along the bottom there drinking, there's quite a lot of evidence that they might go through psychological defense mechanisms of denial. But as drinking continues, they will develop potentially organic brain disease, which will cause lack of insight, because that part of the brain that has to do with identifying insight is damaged.
Oh, God.
Known as anosognosia. Does that make sense? Now, I'm not saying everybody gets it by any means, and I'm not saying you can't have both. I'm just saying that that's a model that helps me potentially understand it. So let's go back to Jean. The brother called the GP, and you can see Jean was admitted into hospital. She went through withdrawal, and they identified the risks of developing a Wernicke's. So they gave her intravenous Pabrinex, that's vitamin B1. They also noted that she had a bit of trauma because she'd fallen down the stairs. And she had bruising on the lining of the brain, a subdural hematoma. Note, she stayed on the ward for 11 to 12 weeks. And this is important. I want you to remember that 11 to 12 weeks, that sort of 3 months, because during that time, she made a remarkable recovery. Her confusion became much less, according to the nurses. She was compliant, happy. She was chatty to the nurses. She was eating well. She knew her way around the ward, and she was happy to go to the alcohol treatment services when she was discharged and looking forward to going home. In fact, it was going so well that they introduced the discharge nurse to help organize, or whatever they do these days, or the junior doctor, or whatever, to get her home. Now, the next slide is a verbatim conversation that I had. The next slide was a verbatim conversation I had with a patient that I saw on the ward. And what I've done is I've transposed it into this scenario.
So you mean?
Could somebody's on mute? You could mute, please. Transfer it into this scenario. So this is a real live conversation I had with a patient, and I've cushioned it into Jean here. And this is the conversation. Look at this. It's quite a fascinating conversation when I look back at it and think about it. This nurse went into Jean just as visitors were leaving. How are you today? I'm fine. I hope I didn't interrupt any visitors. It's okay, my husband has just left. How long have you been married? Many years. Are you still living with him? Yeah. Are you going to live with him when you are discharged? Of course. Are you going back to your own house when you leave hospital? Yes. Without doing any background work, the discharge nurse might say, ah, bingo, I've got somebody looking after Jean, take responsibility for her. She's going back to her own home, and it looks like her marriage is back together. But the discharge nurse knew something slightly different, because she didn't see the husband as coming in to visit. So she asked a follow-up question. So you will be living alone then? Yes. What's happening there? She's contradicting herself. Well, let's get the facts. Facts are, we know she lives alone. She is contradicting herself. We know she had no visitors. And we know, because she's been on the ward 11 weeks, that the husband has not been in contact at all. She hasn't been in contact with the husband for years. What is going on? Well, let's unpick that conversation. Firstly, you'll notice from that conversation, the questions are highly leading. Example, I hope I didn't interrupt any visitors. Within that, hope, as it were, is the premise or the assumption that she had visitors. I have suggested, or the nurse suggested to Jean, that she had visitors by asking the question that way. Now, when you have memory problems, your memory is like a scientist. It is going to try and accrue information and build that information in, and it will take any suggestion, and that suggestion can become a false memory. And this is what we call a momentary confabulation. Jean believes that her husband visited her because the suggestion was made to her. Thirdly, it's a belief. It's not a fabrication. It's not a lie. It's not a deception. But she actually believes it. Rather like you believe that you last spoke to so-and-so a few minutes ago. It's as real to her as your memories are to you. You'll also note that she's contradicting herself. What's that about? Well, people don't contradict themselves like that normally. And this is because she can't remember 3 sentences ago. And last but not least, she still thinks she lives with her husband. What's that about? Well, let's explore this a bit. Let's take an overview of memory, because now the reasoning's been hit with Jean. Now the memory is starting to be hit. She has a working memory. Now, the working memory enables you to synthesize the information that you're getting now, making sense of it, and sorting it out in your brain and understanding it. And then you can respond to it. That is your working memory. Her visual memory is intact. So if you're a nurse and you know her, she will recognize your face and she will be familiar with you. This is why she can walk around the ward, because she's got no visual memory problems. But if you give her verbal information, her ability to learn new information has been heavily destroyed. And hence, she has a proneness to be suggestible, contradict herself, and confabulate. Last but not least, she operates very well in a structured environment. Why is that? That's because she's got the nurses telling her what to do. She's got meal times given to her. She's got a visual memory intact, can walk around the ward. She's able to cope with, she recognizes people. She can see signs and all this sort of stuff. And the same will apply if she was in a nursing home. or any structured environment. She can take cues from around her and they will direct her in the right direction, both psychologically and physically. This is why the nurses feel she's good and ready to go home. So let's just summarize that. She's got reasoning problems and she's got a short-term memory of a gnat. She comes out of a structured environment, she'll be all over the shop. I mean, you don't need to be a psychiatrist to know that. It's really in your face. And let's look at her long-term memory. When we see the genes of this world, we go in and we make assumption as clinicians. We will go in and we'll say, this person, you will know, if you've done your homework on the patient, that this person has been 5 times in the last 6 months into this acute ward with alcohol-related problems. And you will go in, as I do, assuming that the patient remembers that and hence will learn from those adverse life events. But what's happening with Jean is the thiamine now, the lack of thiamine, is destroying her hippocampus. And she is losing memory that are already entrenched. She's losing her long-term memory. And ladies and gentlemen, you can lose up to 25 years of your life, complete and utter ablated. What does that mean to Jean? That means that she doesn't remember all the horrible things that have happened to her. Indeed, if you think about it, if you ask a 50-year-old who's lost 25 years of memory, where's she psychologically going to be living? 25 years ago, before her problems have ever begun. She hasn't learned from those experiences. They don't exist anymore. Hopefully, they don't exist for you. They just never happened. That's the effect of long-term memory problems with this sort of condition. Jean gets discharged home, back to the same environment, because it's not been thought through. She's not been diagnosed. All right, she contradicted herself, but so what? We know she's got poor impulse control, difficulty reasoning, risk management problems, lack of judgment, lack of insight. Hey, ladies and gentlemen, what are we doing to this woman? We're sending her back to get drunk. She doesn't even remember she's been in hospital. When you interview her at home, says, what hospital? And when the alcohol treatment service is called, it's completely meaningless to her. Of course, she doesn't want to go to work with the alcohol treatment services. Now I'm going to try and introduce yet another concept for you that is pertinent, particularly in the severe end of alcohol-related brain damage. I want to just review Jean's cognition. I've extracted some of the reasoning and memory problems that Jean has. She can't remember how much she's drinking or when she had her last drink. So every drink she picks up is the first drink of the day, even though there's a bottle over there that's half empty, because she will not remember having drunk that. She has no understanding or insight into how alcohol's affecting her and can't remember a health warning or anything like that. And in addition, she's got all these other problems that are going to make her vulnerable. Vulnerable to what? Vulnerable to drinking. Poor risk management, lack of insight into how drinking's affecting her, lack of reasoning ability, being able to put two and two together to make 4. She doesn't understand or have insight into how it's hurting her. You put those things together, and I argue that you reach a tipping point of cognitive damage where you fall into a trap. And that trap is where alcohol misuse and thiamine deficiency will cause the cognitive damage. But at a certain tipping point, cognitive damage will set the circumstance, the environment, and the situation that will facilitate further alcohol misuse. Lack of insight, lack of risk assessment, lack of understandings, suggestibility, all this stuff. So in effect, you've now got Jean in a vicious circle of cognitive damage promoting alcohol misuse promoting further cognitive damage. And this happens in quite a few people towards the end, the severe end of alcohol-related brain damage. Over the next year or so, she fell out with her brother. And enter Paul. Now, I don't need to tell those practitioners around this table what can happen to somebody who's as vulnerable as this. You don't read much about it, about alcohol-related brain damage, but I've worked with dementia much of my life, and you can see the older abuse, the abuse of finances, of sexual abuse, of property abuse, of social abuse, of violence that happens to people who are not looked after when they have these horrible diseases. The same, ladies and gentlemen, happen to people with ARBD. She increased loss of weight. Her confusion got worse. She collapsed and was readmitted into hospital as an emergency. But this time, the hospital was very, very busy, as you will know better than I do. The NE departments, people lying on stretchers and goodness knows, and nurses and doctors worked to their bone. You see, they picked up the subdural with a scan, and they gave her some withdrawal medicines, but they didn't give her the thiamine. She went into an acute Wernicke encephalopathy, double vision, unsteady gait, problems in reasoning, speech, neurological problems. But she survived it because they eventually got some thiamine into her. However, she was left with permanent brain damage. This lady, could somebody turn off their speaker, please? Mute, please. This lady was put in a nursing home, age 48 years old. In a nursing home. And time again, working in alcohol-related brain damage, you come across such people. She actually has Korsakoff syndrome. And you'll be coming across this later in other presentations. She has a profound short-term memory loss. She has entrenched long-term memory loss. What happens when you've got entrenched long-term memory loss of Korsakoff's? You can develop fixed confabulations. And her brain has sorted out that she's actually living in a hotel at the expense of her brother. She has significant reasoning problems and neurological difficulties. She's 48 years old. God willing, she's perhaps just over halfway through her life. What has happened to this woman? She's gone from a potentially reversible reasoning and memory problems into a relatively rare, avoidable, long-lasting, if not permanent, destructive disorder that has wiped out the very soul of a being. Let's just explore that last statement of mine a tiny bit. I don't pretend to understand how people feel when they've got Korsakoff's. And hopefully the presentations that AC UK will be giving you will give you much better insight than I can. But let's just put a dipstick in to get a sense of what they might be experiencing. I want you to do a little exercise for me. You'll be pleased to know it's nothing physical. It's a mental exercise. I want you to think perhaps about Christmas time that's just passed, or last year, or something that nice has happened to you. Perhaps your first love, perhaps birth of a child, perhaps, I know, a lovely holiday you went on, fun with your family, holidays, those sort of things. You have a sort of photograph album in your brain, really, don't you? And you can sort through them. Some of them are a bit faded in terms of memory, but they bring you a warmth, don't they? And then also, you can think back at those sad times, can't you? When you've had bereavements, family rows, breakups, whatever. And they're in the picture album as well. Now I want you to think instantaneously about now and about listening to me whittering on. And quickly moving through that, I want you to think what you're going to do after this presentation. What's your plans for this afternoon? What's your plans for this evening? Tomorrow? Summer holidays? When are you going to see your relatives again? The phone calls that you want to make? The problems that you got coming across ahead of you? The anxiety-provoking problems? I want you to think about that. Because what you've just done, ladies and gentlemen, is you've time traveled. You've time traveled from past, flitted through the present, and now you're anticipating the future. You've psychologically time traveled. This is known as the autoenetic consciousness. You've moved through psychological time. You can anticipate the future because you can remember what it is that you anticipate. It enables you to have a sense of yourself. All those lovely and sad memories from the past. They are part of you. They're part of your very being, of your existence. They are why you are where you are now. And then you've got the future that you can plot and move ahead. This is almost your very being. In Korsakoff's, you're locked into the here and now. You can't remember what's coming up. You can't anticipate. You can't look forward to things. You can't dream about seeing your loved one again. You can't dream or think about the football match that you want to watch this evening. You can't do that because you can't remember there's a football match this evening. You can't go back and open that photographic album from the past. The concept of time has gone. The concept of you has gone. You are locked into a goldfish bowl, which is traveling through time, but you're in the still waters and you don't know you're traveling through time. You're just locked in there. A cognitive goldfish bowl. Time passes without you knowing it. You have no insight or understanding, no memory for the last 15 to 20 years. You can't anticipate or look forward to anything. You are locked in to a very small here and now, forever. That is just a glimpse of what I anticipate people with Korsakoff syndrome experience. So, ladies and gentlemen, what is alcohol-related brain damage? Well, I can put together a nice overview sentence for you. And you can take that away. But if you just take that away, you're missing the clinical empathic issue. You're missing the importance of understanding alcohol-related brain damage. I can reiterate the Venn diagram for you. But unless you empathize and try and understand these problems, it just becomes yet another drunk person who turns up at A&E time and time again. How much of this problem is out there? Well, if you look at a very large study, quite recent, at people who are fundamentally heavy drinkers, you will find that a proportion of them have no cognitive impairment. Some will have isolated reasoning deficits. And some will go on and develop reasoning deficits and memory problems. And then some will develop much more global intellectual impairment. If you look at people who are attending alcohol treatment services, and now there are lots of these studies, and they go back for many years. This is just one, which is fairly reasonable representative. I mean, they do vary, of course, but a third of people attending the alcohol treatment services had memory problems. But look at this. Visual memory was intact, working memory was intact, and over half of them had proven psychological reasoning problems. I wonder how our alcohol treatment services adapt. I wonder how our nurses adapt for those people. It's very subtle, you see, some of these problems. So how can we identify these sort of people, these subtle changes early of reasoning problems? Well, actually, if you take the time and you've got the time and you've been commissioned to do it, it's actually not tricky. Let's look at some of the warning signs. The obvious warning sign is that people that have some sort of memory, people that are drinking enough. And this is based on Oslin's work right back in, I don't know, 1980s, that if you drink 30 units and you're a woman, or 50 units and you're a man for long enough, 5 years minimum, probably longer, against a background of social drinking, there's a very strong chance you will have changes in your brain, depending on your genetics, nutritional intake, etc. So we've got one group of people that are probably at risk. Got another group here. Those people that are saying their memory is a bit slippy, or other members of the family have noticed it, or you pick it up on simple questionnaires, psychology questionnaires and screening instruments. And how would we all organize this? Well, we might look at those people that have physical risk factors for cognitive damage. Fatigue, insomnia, anxiety, apathy, loss of weight, reduced BMI, recurrent vomiting. They can't hold down any B1, vitamin B1. There's that relative increase in carbohydrate intake. Neurological problems. What sort of people do you think would experience or be at high risk of experiencing these problems? People attending alcohol treatment services, we know. Frequent hospital attenders with alcohol problems. Those people that you can't discharge because of alcohol problems and disruption of their psychosocial lives. The homeless, and perhaps prison populations. These are the people that are going to be high-risk populations of alcohol-related brain damage. Of course, you get them in other populations as well. You see, ladies and gentlemen, Let's see what could have happened to Jean. If Jean had been treated for the Wernicke's, she would have gone through what she did the first time round. She would have improved over 3 months. Her cognition would have improved. Dramatic improvement. It's like a Lazarus sometimes. People come in and can't walk. And if you can look after them somewhere for 3 months, they would improve, provided they're abstinent. But some of them will still be damaged cognitively. But if you continue managing them for 2 to 3 years, a significant proportion will improve. There will be some people with residual brain damage. Now, we say to ourselves, gosh, 2 to 3 years, how do you look after these people 2 to 3 years? But when you're looking after dementia services, that's what we do. When we're looking after head injury people, this is what we do. This is nothing special. You see, the problem is 75% of these people will improve or get better. Look at this brain. This is the brain of somebody who's a heavy drinker, 30 or 50 units a week for 5 years or more. Going through a year of abstinence, look how the brain heals and cognition improves. Good nutrition, cognition improves, the brain cells grow again, the person improves. That person would have to be under a care plan, perhaps under the Mental Capacity Act. So let's look at the points to take home. ARBD is basically this. We know, despite guidelines, national guidelines, whatever, Wernicke's is often missed and undertreated. A low threshold of risk for Wernicke's must be taken. The person may not even have Wernicke's, but you feel they're at risk of developing Wernicke's. These are critical moments in a person's journey. However, ARBD isn't all about Wernicke's. ARBD is this subtle, slow, dangerous onset of reasoning problems, predating by years the crisis. It's very common in at-risk populations. It's underdiagnosed. It can be prevented. Most people will improve or recover if treated. Interestingly, if you go past the tipping point, it may become a self-perpetuating disaster. ARBD can promote further drinking. And a lot of people with ARBD don't realize they have it. And of course, not just relating to alcohol treatment services, but if you've got a person in your inpatient wards or in your nursing home or wherever, and you expect that person to comply with treatment and you send them out and you don't cater for their cognitive damage, you can't blame them. See, are we missing a trick? There's no randomized controlled trials in the management of ARBD. I'm not going to pretend that there are. But there is a lot of experience that has been recruited in case studies and follow-up studies. What little evidence there is shows that actually a purposeful intervention based on basic management of head injury skills and use where necessary of the Mental Capacity Act can actually revolutionize somebody's life. Not only that, but it reduces the load on acute inpatient bed services. You see, we might have been able to help Jean, ladies and gentlemen. She might be an active member in the community, like many patients that go through ARBD services become. See, it wasn't her fault that she got permanent brain damage. Just think about it. Perhaps if the district nurse had done a simple questionnaire about cognition, perhaps the mini ACE, or perhaps the alcohol-related brain damage, the alcohol treatment services had realized that she was at risk of cognitive damage. Perhaps done a simple screening instrument, perhaps picked up that she'd lost weight, wasn't eating, and perhaps alerted the GP. Perhaps a more purposeful intervention, or more deliberate intervention, or more active intervention could have taken place. Perhaps the A&E could have said, oh, this woman's come in a few times. This woman's really quite poorly now. Perhaps she needs a very brief cognitive assessment. Perhaps she needs to be seen by somebody, best interest assessor. Perhaps if a care plan had been commissioned, the hospital management, the trust management and the commissioners have got their act together and identified that these people don't get any help at all and are banged up in nursing homes. Perhaps if they'd commissioned a person to develop a care plan. Perhaps, ladies and gentlemen, Jean's problem is our fault. If you want further information, we have a little website that we're growing on ARBD. Thanks.
Just chatting away to you there, I suddenly realised I was on mute. So I've unmuted myself. Here we go. So Professor Wilson, if you could start your presentation now. If we've still got people unmuted, could you mute yourselves? And I'm going to put some of the questions that have come through to Professor Wilson. So if you'll bear with me. So start off with some of the comments that have come through. First of all, from William, definitely have protocols as far as ARBD is concerned, but aimed at people who will turn up, and tends to get complicated with non-attenders, especially those with ARBD. We generally pick them up through social care. That's great. I think sometimes there are problems there as well. From Tracy, equally talking about Jean, she may not have wanted to reduce or address her alcohol intake at this time and may have required more emotional or psychological input first. Maxine has asked how you go about getting a diagnosis from health for this. And if I'd like to jump in there and say, I think that's one of the problems, is that we don't have pathways necessarily in each area of the country. And it's one of the things that we're hoping to start establishing as part of this cognitive impairment independent drinkers project that we're doing. And there will be information in the guidance on that. Someone else has mentioned that there are issues around Jean's mental capacity. I think that's very much at the heart of all of this. From Jackie, GP tends to be the starting point to refer onto the relevant diagnostic service if she engages with this. I think that's a key point. And from everything that Professor Wilson has said there about whether Jean will realise and acknowledge that there's a problem, that is a key issue. May come to a point whereby she's putting herself at higher risk from harm, such as self-neglect, and an individual comes to the attention of safeguarding. We've got some more points around that safeguarding point in a little while. Andrew has mentioned that his friend's child has FASD, fetal alcohol spectrum disorder, and the behaviours and cognitions are the same. Yeah, a different form of alcohol-related brain damage, of course. It's an onerous task to intervene, says somebody. DOLS, MCA, responsibility to fund placements, diagnosis, and so forth. I agree. Again, I think this is part of the problem why it hasn't been tackled effectively, is because it is so complicated. And I've got a question from Sophie to Professor Wilson. Would you not describe her presentation during initial admission and subsequent discharge and decline as being due to Korsakoff's?
It's quite interesting. What we've done is, you see, Korsakoff's, if you actually go to the sort of source documents on, this is a semantic discussion, quite rightly say. There are a number of words or names that you can use for these conditions. Indeed, the Americans will talk about alcohol-related dementia as opposed to Korsakoff's and alcohol cognitive or ARBD. Now, the reason we don't use the word dementia is because that implies, by definition almost, that you can't get, that if somebody has dementia, it is a progressive disease for which there is no interventional treatment in terms of getting them better. And that's not the case with alcohol-related brain damage. Hence, we've removed the word trying to remove the word from dementia from the vocabulary. With regard to Korsakoff's, Korsakoff's is a, if you actually look at the Korsakoff syndrome, it is characterized by 3 or 4 different psychoneurological manifestations. So, for example, you'll get the ataxic gait, you'd get the cognitive confusion, and you get neurological ones and eye signs, for example. What it doesn't pick up, though, is the early reasoning problems and the issue that are so prevalent in alcohol-related brain damage. So what we've done is we've generated this concept of alcohol-related brain damage, which includes the term Korsakoff's, but doesn't, and therefore doesn't exclude those people, the majority of people who have alcohol-related brain damage who do not have Korsakoff syndrome, but may develop it later, but not if there's an intervention. So that's the reasoning behind it. And it's a nomenclature which is not recognized in the ICD yet or anything like that. And I don't suggest it should be. It's a pragmatic way of trying to get focus on the management of people with cognitive damage due to excess alcohol ingestion and thiamine deficiency, whether they've got Korsakoff syndrome or not.
Thank you. Thanks very much. Right, something else here. In relation to Jean, it's clear to me that there's a necessity to use and weigh the relevant...
2 seconds.
Can you please mute yourself if you're still on the call? Thank you. Use and weigh the relevant information in relation to her care and treatment on either a decision or performative level, which is also causatively linked to the ARBD. I worry, though, that Jean's decision-making will often be referred to as a lifestyle choice and just an unwise decision, and no one will consider or apply the Mental Capacity Act in these situations. Please do come back next week for Professor Michael Preston-Schute's webinar on using legal powers. It includes the Mental Capacity Act, Mental Health Act, and more on that one. Do you ever find that when people get so severely cognitively impaired, they forget they have an addiction, if no access to alcohol, or if there's a change in the environment?
Yeah, that's a very interesting question. If you manage somebody with a significant degree of cognitive impairment, and you get them first through what we call phase 1 and 2, that means you physically stabilize them, then you give them a good 3 months of protection and good nutrition, and build up a care plan with them and develop good relationship with them. You can then go into phase 3, which is the therapeutic program, and during this time there is a very big number of people, not entirely all people by any means, but I would have thought something in the order of about 2/3, that actually, it's not so much that they actually regain some of their memories. They've been educated over a period of a year or 2 about alcohol. They've retained that information as their memory improves. And our experience is that we only got something like, I think it was 15% alcohol relapse rate after they'd been, as they were going through and during and after treatment. And a lot of them were very frightened of alcohol by the time they'd been through, or never wanted to go back to it. So
Okay.
it is with an educational program as well. It's all on the, all this stuff is on the arbd.net website. There's a manual there, there's all that sort of stuff. And so it's all available completely free if anybody's interested.
Lovely, thank you very much. Okay, some more comments. It's a razor's edge and services are not set to pick it up, and there's a reluctance to diagnose, certainly. And again, on people with ARBD, they don't adapt. Even responding to the initial letter is an issue for people with cognitive impairment, and then they get discharged. Yeah, we've had another question. Apart from referral to diagnosis services, what other things can we do to help if we are not medical services? And that is something that we're going to be covering in the cognitive impairment training. There is a lot that can be done. If you look at any of the blue light materials, you will see that there is a lot that can be done for dependent drinks. If you go onto the Alcohol Change UK website, you'll find out more information about the blue light projects, of which this is part. So a lot that can be done, whether you're in whatever capacity you're speaking to someone who has some form of cognitive impairment. Here's an interesting one. Why is the number of units such a big difference for men and women? 30 for women versus 50 for men.
It's a consequence of, it's a consequence, this is based on Oslin's work, as I said, and it's basically a consequence of the gender differences, sorry, sex differences in metabolization of alcohol, which would be in turn related, I assume, to the endocrine system, hormonal issues, and those sort of things. Obviously, also, it would be affected by age. Somebody who's past their sell-by date, like me, just needs to sniff a glass of wine, and it doesn't have the same effects as it had when I was an 18-year-old medical student. And it's also maybe associated with a whole lot of other genetic components. But gender is certainly, sorry, sex is certainly evident in the both biochemically and also in the epidemiological profile of people with alcohol-related brain damage. So, for example, women usually present a decade earlier than men, generally speaking. Of course, there's a lot of overlap. So there is quite a lot of evidence behind it from both science and anecdotal perspective. Thank you.
We've got another comment here from Shirley. Mental health services still refuse to diagnose, treat and support people with ARBD because they're alcohol dependent. Oh yes, that issue. Yet it can often be the case that people are self-medicating with alcohol to stop themselves having to deal with their mental health traumas. Gosh, we could spend a couple of weeks on that one, I think. Absolutely agree with you there. From Jackie, holistic approach, getting the right services at the right time, promoting community engagement and meaningful activities, and providing hope. Again, I'm hoping that the training will cover that as well, that we're doing. Okay, what else have I got here? Lots of thank yous to you, Professor Wilson. Joe has said, it's incredibly frustrating when as a support worker, you notice and highlight all of these issues, but treatment services don't take it further due to it being alcohol related and put it back on the individual not wanting to make change. Yep, we get that a lot.
One of the, could I interrupt there? One of the interesting areas here is that all people who drink excessive amount of alcohol, as I've demonstrated, do not get alcohol-related brain damage. Consequently, almost politically, socio-politically, we've got to get across that these people have dual diagnoses.
Yeah.
And that's a coinage which is often found in mental health services. So the person has alcohol dependency issues or alcohol misuse issues, but they also have a severe brain damage. And this is why it's quite important often to emphasize that it's thiamine deficiency as much as alcohol that's a problem. You can get Korsakoffs if you starve yourself, irrespective of how much you drink. So it's worth conceptualizing this as a condition which is concurrent with, but not the same as, alcohol dependency.
Lovely, thank you. We've got here how to differentiate between alcohol dementia and Korsakoff's.
Well, as I mentioned, these are semantic terms, and this is in order to avoid this confusion, we talk about alcohol-related brain damage.
Thank you. Okay, so G was quite a severe level of ALBD. Working in the hospital with patients presenting with milder ALBD, we've had great difficulty finding appropriate discharge and short-term support. Again, I'm hoping that this, obviously we recognise that this is an issue, and we are hoping to address that in the training. From Anna, we have a guy who vomits a lot and has done for years and eats tons of sweets, not much else. Are those things which could be related to his alcohol misuse? I would say certainly in some way they may be. Well, Professor Wilson, do you want to?
Well, what can happen with some of the more stranger aspects of alcohol-related brain damage is that you can get preoccupation with different types of drink or food, and non-alcoholic drink and food, and you can get people quite a sort of, inverted commas, obsessional about particular types of food. They often have quite severe damage to the front part of their brain when they're experiencing that.
Okay, thank you. I've got a question here. Can you recommend? Oh, I've lost it. It was there and then it wasn't. Can you recommend a cognitive questionnaire to detect early ALBD, please? I will refer you to the guide. I think this is appropriate time to do that. I will refer you to the guidance that we're producing on this for responses to that. Also concerned that alcohol clients not being prescribed thiamine by their GPs who know the person has an alcohol problem and a dependency. Yeah, again, I think that's something to be covered in the guidance. There we go. Is daily thiamine for at-risk groups a way to attempt damage limitation these complicated to manage groups? Please see the webinar on Pabranex and how effective that can be. Do you think it's surprising that there are so few reported ALBD cases that have come up in the Court of Protection? I can only think of 3, but one is helpful as the expert witness eloquently explains how ARBD and executive dysfunction impaired the person's decision-making capacity. Again, when it comes to looking at legal powers, and if you have a look at the guidance and other guidance that we have produced in the past, I'm thinking of Learning from Tragedy from the Adult Safeguarding Reviews on the Alcohol Change UK website, more information on that. For a medically stable but cognitively unstable patient with Wernicke's encephalopathy, what would be the recommended thiamine dose? I think that's a clinical decision to be made there. Professor Wilson, do please jump in and
the intravenous thiamine is dosages are well rehearsed on all the national guidelines, including the BNF, the Royal College of Physicians, the Royal College of Psychiatrists. They're all there. I wouldn't like to quote them without looking them up to make sure I'm up to date, but it's all there. And as Lauren has said, there is some variance in it depending on the response of the patient.
Thank you. Would you only be prescribed thiamine for deficiency due to excess alcohol, or can you be thiamine deficient by other health reasons? Yes, you can be thiamine deficient. As Professor Wilson has already said, that just not taking enough in the first place. I've known it occur after bariatric surgery, for example, thiamine deficiency.
And hyperemesis gravidarum, which is extensive vomiting during the pregnancy.
Yeah, thank you. We have to fight so many barriers to try and get help for clients, social care, past to mental health to GP. And this then takes so many weeks for a client to even see anyone, and therefore we're losing valuable time for the client. Any advice?
Well, fundamentally, this is a commissioning and senior management problem. This is why I think a lot of us at grassroots suffer, because in my opinion, and this is the way we did our service, we got the commissioners, the acute hospital and the mental health trust together, and we got them to commission the service. And unless it's commissioned, people are going to bounce around like ping pong balls. Yeah,
absolutely. It seems like more education is needed in communities and primary care about risks to the brain through drinking. Here, I agree. Is there any kind of short user-friendly slides or video we could use with clients?
There is, on our website, thearb.net, there is a nice discussion between one of our network nurses and working in an acute hospital and an ARBD patient. I mean, it's, I think AC UK will probably be working on this, as we will with them if they want us and so forth. So there is potential there if it's not already on the websites.
Thank you. One from Naz. How do we get help for people who drink a large amount every day but do not realize that they have an addiction? They don't get support from GP or mainstream support due to bad experiences. Again, I would say have a look at the blue light materials there. And I would also, for these people, I think maybe support for those who are caring for them is really important as well. So at NACOA, for example, ADFAM, might be organisations that can support their loved ones while they're supporting the drinker. And we've also got the blue light family manual as well, which you can find on the Alcohol Change UK website. How to distinguish between alcohol-related brain damage and comorbid dementia or other forms of such as Alzheimer's vascular, as alcohol can increase vascular damage and MRI-CT can show hippocampal shrinkage similar to AD.
Well, fundamentally, it is evidence that there is a causative, potentially causative relationship. So you're looking for very heavy drinking, subsequently followed by a cognitive change, whereas in dementia, and it can be difficult with dementia, the vast majority of people with dementia, like Alzheimer's, frontotemporal dementias, and those sort of dementias, won't actually present with a background history of very heavy drinking. Some will, and that's where you've got complicated problems, and you have to see how the disease progresses and if a person stabilizes when they're not drinking.
Thank you. Final one here, I think. If seeing dependent drinkers in the community, is it still useful to complete cognitive screening when they still have alcohol in their system?
Julia, who's going to be giving one of the AC UK presentations, is a community drugs and alcohol psychiatrist who is pioneering work in alcohol-related brain damage. Not only is she giving the presentation on AC UK, but she's also got quite a lot of YouTube presentations as well. And it's really worth listening to her. She's very, very good on this sort of area. In terms of, from my perspective, my circumstances and background have been relatively easy in that respect, in that most of the people that I've picked up are people that have been dried out through a withdrawal program, referred from a hospital or nursing homes, etc. But in reality, what we recommend is that if a person is going through withdrawal, as soon as they're off the withdrawal, it's worthy of doing it, of doing cognitive investigation, and not wait for 3 months for them to see they get better, which is often quoted by some people. And secondly, if somebody has a persistent cognitive damage evident, irrespective of how much they're drinking, because their drinking will fluctuate over time, then it's worth perhaps investigating further.
Lovely, thank you, Professor. So I think all that remains to say at this point, a couple of questions keep being asked about the presentation. It will be available as a recording rather than the slides. It's going to be in each local authority, and we're hoping to get it on the Alcohol Change UK website as well. If you have signed up for this webinar, that does not mean that you're automatically signed up for the others. You will need to sign up for each one individually. There are plenty of places left, so do feel free to do that. Julia Lewis's talk, by the way, is on the 22nd of February, if anybody would like to join that one. Is that everything? Does anybody else have any questions? If not, then I would just like to very much thank Professor Wilson for this amazing and fascinating talk on ARBD. I'm sure we've all learned a lot, and please do check out arbd.net for all the information that's available there. We also have information on the AC UK website. And please look out for the guidance which will be published in the next few months, and the training that's coming to each of the local authorities who's involved in this project. So thank you very much, everyone, for your time and your attention during this session.